Hello, everyone. Maybe someone could give me a thumbs up if they can hear me speaking from the room. Can anyone on Zoom hear me speak?
I got a thumbs up.
You got a thumbs up?
Yeah.
Perfect. All right, let's get started. Welcome, everyone. Let me admit some of these people that are coming in. Welcome to our research seminar series. Today, we are talking about implementation science in global surgery. We have a couple of good speakers today. Let me progress my slides here. So for those that don't know, the research seminar is an 8-session series to explore methods and outcomes in global surgery. We typically have 2 speakers talk about similar topics and methods, followed by an open discussion. The videos will be posted after the seminar if you want to see them. This is our team. I won't go over everyone. Our first speaker is Dr. Tiitena Ngusi-Mamo. She's an associate professor of pediatric surgery and a consultant general and pediatric surgeon. She works at Addis Ababa University College of Health Sciences and is actively involved in teaching undergraduate medical students, residents, and fellows of pediatric surgery. She has served and still serves in different leadership positions. She was the chair of National Continuing Professional Development in Ethiopia. She worked as an executive board member of EMA and the Surgical Society of Ethiopia. Currently, Dr. Tiitena is the Global Clinical Director of Lifebox Foundation and the Secretary of the Associations of Pediatric Surgeons in Ethiopia. She has published more than 35 articles in reputable journals and also has taken an active role in review for different journals. Everyone welcome Dr. Tiitena.
Thank you, Ted.
Yes, if you want to share your own slides, feel free. Otherwise, I can share them here.
I think I can share from my side. If there is an issue, I will let you know and you'll share it. Yeah. Can you see it now? Is that visible?
Yes, we can see.
Perfect. Thank you. Good morning and good afternoon, everyone. Thank you, Tyler, for the introduction, and I'm happy to be here to talk about some of our work at Lifebox, and I'll be happy to hear more from your end. So, as you all know, implementation science is one of the newly developing science in medical field, and definitely, even though there are different evidences generated globally on different aspects of surgery, there are still issues on the quality of surgical service at the institutional level. And this is dramatically significant when it comes to resource-limited areas. So as a leader and at Lifebox on implementing different programs, I am one of the witnesses on appreciating the gap on the reality and what is really happening on the ground. And also there are different quality improvement programs or other programs which are meant to address the issues of the barrier on quality services on global surgery or surgical service at the institutional level. So when it comes to implementation science, there are some things we need to address, and today I'm going to share you one of our work and the assessment we did around that specific project that we implemented in different hospitals. So this will be my outline, just briefly saying a few words about implementation science and my experience by implementing clinical program, and also how can we use this lesson learned for future scaling up of the program. So there is a known fact on evidence generated on the different aspects of surgery. And when it comes to surgical site infections, there are appreciable scientific suggested realities which would decrease surgical site infection at the institutional level or at the patient level. But when this evidence is generated, we are also still appreciating high rate of surgical site infection in this site. So science is there, proven facts are there, but the gap on the problem on the patient level outcome is still being witnessed. So what implementation science will do is it's just a form of science. It will address health policy or system by integrating what is appreciated interventions to change the system, and also bringing the quality at the regional, institutional, national level. And there is also a place for scaling up of these programs once there is approved significant impact on the outcome. So when we are implementing this scientifically proven facts as a quality improvement program, there are a few things we need to keep in mind for it to be successful. So when you go to at an institutional level, whenever you don't have a support from both the leadership side as well as the stakeholders or the team who's implementing the program, then there will be an issue of success in using or appreciating the change. And whenever you are also targeting, don't target an individual. Try to target team, all stakeholders which you think are important as a system. And to prove what you are doing, data should be there. You have to show the data to the people because that is a language that can be easily communicated between the implementer, the end user, as well as the leader at the policy level. So you have to make sure that you have a proper way of collecting data and showing how successful your intervention is. Then whenever you are appreciating the gap during training or intervening, make sure that that evidence is well appreciated, proven, and do it in a systematic and continuous way than just one-time training or one-time education to the team. And try to engage the team in developing protocols, in using protocols or standardizing protocols. And at the end of the program, in between your program, try to gather feedbacks, reflect on the feedbacks and discuss around it so that there will be continuous improvement of your implementation. And whenever you are having this kind of program, from the outset, try to think about the sustainability. Don't embark on or bring on the changes while implementing without thinking about how that can be sustainable. Because once you are out, the program will be out and the effect will be disappearing. So make sure that you are having sustainable plan ahead of time. So what am I talking about today? Today, I'm going to talk about the qualitative analysis we did on our experience where we are implementing CleanCut program at 7 pilot sites in Ethiopia. And some selected sites have been created as part of this interview for the qualitative study. But what is CleanCut? CleanCut is a quality improvement program which is used for reducing surgical site infection, and it is literally based on WHO surgical safety checklist. And the program has been piloted in Ethiopia in 2017 until 2018, and 7 sites were selected for the pilot study. So this WHO safety checklist-based program has 6 standard pillars to address the perioperative infection reduction program. And these processes include surgical hand washing and patient skin preparation. The second one is surgical gown and drape integrity maintenance. And the third one is appropriate antibiotics administration, then instrument sterility confirmation. The next one is appropriate gauze counting. The last but not the least is appropriate use of WHO surgical safety checklist. So the program has got 5 phases, and some of them are intermixing in between, but it has 5 phases in general. So from the outset, we will introduce the program to the team at the hospital level and at the policymakers level. So whenever we go to new countries, we will start engaging the Ministry of Health. Whenever we go to new institution and already implementing countries, we will start with engaging the medical directors as well as the CEOs and introduce about the program and identify program implementer team and champions of the program. And the next step is assessing the system, the baseline status of the system. So what does the hospital context telling us? Infrastructure-wise, human resource-wise, and quality improvement wise, and also using protocols and standards. We are also doing process mapping around six standard pillars. Where is the gap? How is it implemented? Are we set good from the outset, or is there any gap? And what are the gaps behind it? So that will be analyzed in a process mapping as well as the fishbone analysis method. And the third, but all part of the baseline assessment is taking actual data. So we will take actual data in the operation theater intraoperatively on the 6 compliances, the pillars, and as a patient transfers to the ward and also being discharged for the first 30 days, we will collect on the outcome, surgical site infection, reoperation, mortality will be collected. And once we have this baseline data for 1 or 2 months, we'll analyze the data with the team at the hospital level. We call it clinical team, and the lead will be the champion. So we will assign one person as a lead. Then after this data has been analyzed, all important stakeholders, starting from the leadership, including ancillary team. So we call it the leadership, the CEO, the OR director, the medical director, and the core team, the nurses, the anesthesia providers, and the surgeons, and the ancillary team members at the central sterilization room, and the biomedical technicians at the laundry room. And all this will be gathered together for the action planning meeting. So the team will present about the data, the gaps, and the root cause analysis of all the gaps will be discussed. Then the solution will be proposed by these team members, because at the end of the day, they are the owner of the program, and they should know what to target and how to address. And once the gap has been identified, different suggestions will be proposed. One is training, refresher trainings, checklist trainings, and others. The other one is regular checkup on the availability of protocols, standards, and tools, and communicating with the leadership to avail simple but not much costly infrastructure or solutions like alcohol-based wraps or medicated soaps and others. Then all this intervention will be done for few weeks or months. Then post-intervention data will be collected to see the impact, and that will be analyzed, and an additional all-inclusive stakeholder meeting will be called as a phase 5, and we call this beyond clinical, or the sustainability strategy of the program, where everyone will get an assignment and the program will be followed. How impactful will it be, and what additional QA ideas can it be generated as a hospital lead? So coming to this qualitative analysis, so we did this qualitative analysis to assess our program, how successful it is, what are the barriers behind, and what are the facilitators to make it perfect or good, and how can we take it to next step. So once the IRB has been approved both at Addis Ababa University and Stanford University, data collectors has been assigned to do a structured interview for 20 clinicians at 4 sites for 4 weeks. And these clinicians include the OR staffs as well as QA lead and also hospital leads. And data has been coded, analyzed, and discussed with the whole author team. So the result is emphasizing with different thematic areas on identification of the barriers and the facilitators. So this table has showed us there are 5 thematic areas assessed: the material resources, the hospital leadership engagement or participating on the issue of this program, hospital staffs, especially the implementer staffs, and also the knowledge, culture, and education and beliefs of the perioperative staffs and data collection issues. So all these 5 thematic ideas has been assessed. What are the barriers behind for making it not successful or difficult to implement? And what are the facilitators for sites where there is significant improvement or make significant success at the area? So when it comes to the barriers in terms of resource and availability of some of the infrastructures or some of the consumables resources has been assessed. So not working autoclave or unavailability of sterile indicators, especially the internal indicators, the unavailability of medicated soap, alcohol-based wrap, are the issues which contribute to as a barrier for failed in compliance to address the preparation of the skin or the sterility of instruments. And when it comes to the facilitators, availability of these things contribute a lot, and also availability of engaged biomedical engineers are also a facilitator, especially in maintaining some of the equipment, including autoclave. As a barrier, an additional barrier for especially related to using protocols, guidelines, and for the data collection issue is not availability of paper and printer in each department. And also budget restriction on that issues has been suggested as a barrier for this program. When it comes to the hospital engagement, when you start implementing this program, there are few sites where we directly engage the team at the perioperative field than starting from the administrator. That has a big barrier, especially in availing some of the resources, including medicated soap and alcohol-based wrap, because the hospital leadership didn't take the program as their own. They think it is an outsider program implementation. So, but sites where there is administrator buy, as well as having a purchasing power by the administrator, had made the program successful, or it facilitates the program implementation. And when it comes to the hospital staffs, thinking the program as a burden, doing surgical safety checklist as a time-taking issue, as a culture, has contributed in withdrawing or not successfully engaged into the program. But motivation by the increased improved patient outcome and engagement of the team with a team dynamic and one-to-one conversation, as well as having prior quality improvement program implementation experience, is some of the contributing factors on the hospital staffs. And when it comes to individual level knowledge and education, the knowledge about SSI, misinterpreted data on SSI, and the importance of internal indicators has made it a barrier. And from the outset, orientation of the team around these 6 standard pillars by either LifeBox or the hospital clinical lead had made the program engaging and successful. And the last thematic area is the data collection issue. As you know, when it comes to resource-limited areas, the electronic medical recording is not that much strong in some of the setups, and paperwork has its own issues. There are wrong data documentation, missing of the documentation, considering it as time-taking and additional burden. All these issues contributed as a barrier, and also when you take the data entering into the software, the handwriting issue and others become a barrier for successfully having the data and interpreting it. But teamwork and division of responsibilities, especially for data collection, and having a schedule for the data collection make it easy for implementing clinical program. So the reflection from these interviews around suggestions on the success of the program is, from the outset, try to engage the hospital leadership and from the outset, don't think that all resources should be there for elevating or successfully implementing clinical, but analyzing the gap and stressing the minimum needed resources at the hospital level to have safe surgery and anesthesia should be communicated with the hospital leadership team. And also creating a sense of responsibility and team-based approach is also important. And whenever the data has showed you the gap, make sure that you provide the training and also share the data, not only the clinical team, with the hospital staffs, all the stakeholders which you think are engaged in the perioperative surgical services. And through time on the sustainability plan, make sure that you created a way to incorporate this data collection into a daily routine as part of the work, because it's part of the system changing approach for safe surgery practices. And at the end of the day, for scaling up at the national or regional level, engaging teaching institution, because this teaching institution has got residents and fellows. When they learn from the program and the impact on patient outcome, they will cascade it wherever they come from while they are assigned as their working institutions. So as in conclusion from the study, this qualitative study has showed us there is context-specific factors should be assessed relevant to LMIC, and it has an impact on the system. And stakeholder engagement from the start is important. And as much as possible in each steps, try to share the data and the findings at the hospital level, as well as the national level, as a teaching strategy. So all this will make it why implementation, research implementation size is successful whenever you are considering a system is owned by the team at the hospital level, the leaders contribute significant impact, and knowing the gap at the institutional level is specifically to the site that you are implementing. There is no generalization. What works at Black Line will not work in Jumma Hospital. So you have to make sure that the context is well addressed beforehand, and all the sites, the gaps, the opportunities available should be assessed before implementing any program. And try to create strategies to motivate the staff. For example, sharing ahead of time what the impact on the patient level is, how that can change the working environment, the team spirit, and others will make the team motivated to work more on different quality improvement programs. So this is some of the lessons that we get from our qualitative analysis of our program. And I'll be happy to take any questions, comments, or feedbacks. Thank you so much. Back to you, Tyler.
Thank you very much. I think we're going to do questions after the second speaker. We'll do them both at the same time. So I will share real quick. I can remember how to do that. One moment here. All righty. So our second speaker today is Dr. Hadiza Galadansi. She's a professor of obstetrics and gynecology at Bayero University, Kano, Nigeria, and director of a World Bank-supported Africa Center of Excellence for Population Health and Policy. She has published over 100 articles and has established a research network and delivered over 20 studies with the World Health Organization, the MacArthur Foundation, FIGO, MRC, and the Bill and Melinda Gates Foundation. She is an inspiring model for women, particularly women clinical academics, being the first female obstetrician and professor to be trained in the Kano, Nigeria. She has won multiple awards for her leading work in maternal health, including FIGO Women Award 2018 and 2023 Heroine of Health Award. She has served as a member in several initiatives, including Align, MNH, and she has trained and mentored over 2,000 undergraduates, postgraduates, and residents. Everyone, please welcome Dr. Hadiza Galadansi. And you can share if you have the ability to.
Yeah. A very good morning, afternoon, and evening. For me in Nigeria, it's well, I would say late afternoon, whilst I'm sure where you are, it's probably morning. I want to start by thanking, the organizers of the program for global surgery and social change of the Harvard Medical School for inviting me to share our experience of the emotive trial and how globally as well as nationally we're trying to implement the trial. My outline will go this way, just going through the background, the trial team, the ethical consideration, the methodology, the results, policy dimension, how we've been able to implement it, as well as conclusion, and then, of course, have some questions and answers at the end of the day. Well, just as a background, we all know that postpartum hemorrhage, which is defined as bleeding of over 500 mL or more within 24 hours after a vaginal birth, is a major global problem. It's been estimated that about 14 million women globally every year do have postpartum hemorrhage. Majority of them, of course, in the low middle income countries. And out of this 14 million, about 70,000 would die. And at the same time, majority in low middle income countries. And recently there is a data that actually showed a lot of these women that die because of PPH actually die also from Nigeria, because we have high fertility rate and we have high maternal mortality rate. And when you look at the global picture, actually about a quarter of all maternal deaths are due to postpartum hemorrhage. And beyond just having maternal death, you do have a lot of morbidity. Some of the women will end up with hysterectomy, with the laparotomy. Some will end up with cardiac failure, with renal complications, with depression. Some will end up, dying, and therefore their children having to go through the problem of, growing up without parents. So the mortality and the morbidity is huge. But the big question is, why is it that postpartum is still a problem? Because we all know the interventions. For over decades, we have interventions that are very good in preventing postpartum hemorrhage. I mean, our active management of third stage is basically to prevent postpartum hemorrhage. And we know how to treat it as well. We have the oxytocin, we have the tranexamic acid, the misoprostol, the laparotomies, the B-leach, the balloon, everything. But why is it that it's still a problem? So that's what we went out first to find out. And we found out first, even before we did the study, when we decided to look at postpartum hemorrhage, that there are three major challenges or delays that actually occur in trying to address the problem of postpartum hemorrhage. One is that we miss or we delay the diagnosis, and I'll tell you why. And second is that even when we diagnose it, then we delay in giving all the interventions that we know. And then thirdly is that when we now have done the interventions and it's not succeeding, we now delay to get to the refractory stage of the treatment. So these three delays are the ones that still make PPH still a problem. And to buttress the first one of delays in making a diagnosis. Now, in our own environment, I'm not sure whether in Harvard, whether it's the same thing that is done or in high middle income countries, but I'm sure a lot of places, even in the high middle income countries, is that we estimate blood loss by visual inspection. We really don't have a way of saying a woman has lost 500, 550, 600, 1,000 mils after delivery. What we do is that we look at the blood on her clothes, we look at the blood on the gauze and the pads and the Macintosh and everything, and then we make a guess. And in fact, in some places, even the blood on the floor and the blood in the kidney dishes and in anything that we're collecting. And therefore, most of the time we really underestimate that amount of blood. And to really say it scientifically, we have the champion data. The champion data is the data that we use to look at cabertocin, the heat stable cabertocin. And it's a huge data, global data. And in this data, it showed that at 500 mils, up to 50% of women are not diagnosed as having PPH because they weren't given any oxytocin. They weren't given any oxytocin at 500 mils because nobody thought they had lost up to 500 mils. And therefore, they didn't diagnose PPH. Even at 1,000 mils, which is up here, that is up to 30% of women did not receive treatment, even after they've lost up to 1,000 liters, which is severe PPH, which means this 30% were not picked up as they have lost up to 500 mils. And we did a lot of other studies that really showed when we put blood in various containers and in cloth that has been soaked with blood and say, please, can you guess how much it is? And people would guess from 100 to 800 mils, which really shows that we don't know how to, estimate the amount of blood. Now, in terms of sequential treatment, the second delay, we have the massage, which we usually do. We have oxytocin. We have tranexamic acid from the woman trial. We have misoprostol. We have the IV fluids with oxytocin. These are all the interventions we have. But usually what we do is that we do one and expect that one will work and wait for minutes to wait for it to work. And then when we realize it doesn't work, we go to the next one. We wait for another 15, 20 minutes. We wait for the next one. So by the time you are now doing all, you've spent almost an hour and the woman has been losing blood. So it becomes too late for you to do anything. So what WHO said in about 2012 was that do the motive trial, which means do them together, but nobody really paid attention to the motive trial. And therefore, actually, our own trial decided, okay, so this is the escalation, the last part, which is the third delay. So people, when you use all the interventions I've said, you need to get to the theater. You need to put non-pneumatic additional garment. In the theater, you need to do billing, you need to put the balloon and so on and so forth. So there's so much delay from when you make the diagnosis to realizing that your normal treatment doesn't work to now trying to get her to the theater. 2-3 hours and then it's too late for you to save the woman, especially in our own environment. Then you're looking for blood, then she gets into DIC, then she gets a shutdown, then she gets a heart failure, and on and on and on and on. So we decided that we are going to look at the motive bundle of WHO and try to see when we have a different approach and addressing these 3 delays, maybe we should be able to address the problem of PPH. Basically, that was what we went for. And I will tell you, at the end of the day, what were our outcomes and so on and so forth. So in terms of the team that did this trial, it's a huge global thing. It's not one country, it's not 4 countries, it's not 5, it's not 10, even though we took data from 4 countries. So we have the 4 countries that took data. These are the Nigerian team, the Kenyan team, the Tanzanian team, and the South African team. But then we have a huge statistical team that were in Birmingham, which was the main site of the emotive trial. We also had a mixed method team that was in Australia, in Melbourne, I think in Melbourne University. They were the ones that were the mixed method team. Then we also had the Jafigo team that were the ones that actually helped us in our training model. Then we have the Concept Foundation team that looked at the quality of our oxytocin and tranexamic acid. That's in Switzerland. We had the Health Economics team that were also in Birmingham. We had the WHO team that were supporting it because they needed answers to this problem. And then we had the trial steering committee team. We had the data monitoring team. Then we had Gates and Melinda Gates Foundation that were our funders. And then we had University of Birmingham trial team that were a central team. And even within Nigeria, you can see we had a huge team within even Nigeria. We had the data team, we have the midwives, we have the training, the innovation, the midwife innovation team, we have the statistics team. We had, all different people come together to make a good research team. In terms of ethics, we had to go through so many ethical clearance. Each of these teams that I've said, about almost 15 of them, each one of them had to ask for ethical clearance from their own bodies. So whether it's WHO, whether it's Melbourne, whether it's University of Birmingham, whether it's the FIGO team, each one of them has an IRB. And therefore, they had to take their proposal through the IRB. And coming back to Nigeria, we had to take also our IRB in the state because we use the state hospitals. We also had to do in the teaching hospital because we are in the teaching hospital, and therefore we needed ethical clearance in the teaching hospital. We also needed to go national, the National Ethics Committee, because we're going across states. We were working in about 26 states in Nigeria, and therefore we needed national ethics clearance and ethics committee approval before we could commence the trial. So in terms of, the methodology, as you can see, it's not really complicated if you really go through it. First of all, we had a design workshop where all these different teams that we have said came together. I remember very well in UK, in Birmingham, and sat down and really looked at how we're going to conduct this trial. And then, of course, it's a mixed method. So we had the qualitative arm, we had the quantitative arm. And then we had what you call the pilot cycle, the adaptive cycle. And for the adaptive cycle, what we do is that we took three facilities in each of the 4 countries and tried our intervention. We wanted to see whether it will work. And then based on that, we now analyzed the results and we brought back the members of these 3 facilities, which means 12 facilities all across the 4 countries. And we sat down and co-designed the real intervention based on the challenges and the lessons we've learned from the adaptive side. At the same time, we now recruited 80 facilities across the 4 countries. And the thing is that Nigeria, we had 38 facilities out of the 80 facilities, plus 3 adaptive sites. So almost half of the facilities were actually in Nigeria. And then we're taking baseline data for 7 months. And after that, we now randomize the 80 hospitals into 40 intervention, 40 control. And then we had a transition phase, which is about 2 months phase, where we now transition from the baseline to either intervention or control. And then we now did, of course, during that transition phase, we did the training for the intervention and everything. And at the end of the day, once we now got for 7 months, we're taking data prospectively for the control and the intervention. As I said, we had 80 facilities. So this is how it was divided between the 4 countries. And then what was our cluster unit of randomization? It's actually the hospital. So it's not individual, it's actually the hospital. So the hospitals were randomized, and each of our hospitals, for you to be eligible, you to have at least 1,000 to 500 births in a year. So they were big hospitals across the 4 countries. And then our women, the unit of analysis was actually the women with the vaginal birth. So what was the intervention? The intervention was actually to look at the usual care and then to look at the E motive. And the E motive is the mnemonic for E, early detection. And what did we do to address the delay in diagnosis? We now used a drape. So with a drape, we could actually say the woman lost 120, 130, 510, 520, or 600 or 800. So we could actually say this is the amount of blood loss she's had. And then the M is massage, O is oxytocin, T is tranexamic acid, IV is IV fluids, and then E is escalation. So you do early detection, and then you give the motive trial. And the motive trial, we say you give it within 15 minutes. So not the usual trial, not the usual care. So you put the drape and then you give the motive. In the control, which is our usual arm, we still had the drape so that we can see the amount of blood, but there was no motive intervention, no MOTIVE. We didn't train them on that. So they were usual care, and the usual care was just the way they were doing it. But we made sure they had all the components of the motive trial. So we made sure they had oxytocin, they had tranexamic acid in the facility, but we didn't train them on how to do the motive trial. So that was our control and our intervention. What was our outcome? We were looking for a composite outcome of 3 components. One, from the difference between the intervention and the control in terms of severe PPH, more than 1,000 ml, in terms of laparotomy, in terms of maternal death due to postpartum hemorrhage. And we're just looking for 25% reduction. When we were doing the baseline, it was about 4% across the centers. 4% was our PPH rate. So we wanted to get it to 3%. That was what we powered our sampling, and therefore got our sampling, our sample size. In terms of secondary outcomes, we're looking at how do they detect PPH, how compliant were they in using the component, whether it is in the control or in the intervention. And then, of course, other secondary things were laparotomy, blood transfusion, intensive care, newborn death, and so on. Now, the picture on the right actually showed us that for us to accept any data, you had to put the drape is on a scale. You have to put the drape on the scale. We had to see the amount, the size, the weight of the drape, which is the 0 to 100 here, which means 200 mils. It was 1 gram per mil. And then we needed to see the source data, which is the folder of the patient with the details on the folder. And the reason we had to do is that when we started the trial, we realized that, still people were estimating the amount of blood. They will put the drape, but then they will raise up the drape and just guess the amount of blood. So we weren't sure of the data that came. In fact, we had to lose 6 months of data, because when we realized that, we now stopped. We now threw away that data in the dustbin and started. So for every single data that we accepted, we had to have a picture that supported the data so that we know the data is authentic. Any data that doesn't have a corresponding picture was not acceptable. So this is how the recruitment, we recruited over 110,000 deliveries. You can see from Nigeria, from Kenya, from South Africa, from Tanzania. In terms of our case completeness, 99% of our births were captured across all the hospitals, because we also had another method of knowing how much deliveries were in the facilities. And then also in terms of our pregnancy outcome data, we had almost 98%. And in terms of our discharge data, we had 100%. Now the results. Now this slide, I hope you can see it, even though it's a bit small. It's just showing us that our usual care and our emotive sites and our usual sites were almost the same in every aspect, except that one was doing intervention, one was doing control. You can see that in terms of the numbers of deliveries, all of them had, an average, a median of 1,136. The usual was 1,263. In terms of availability of oxytocin, all of them had. In terms of the age of the patient, you can see 26 as the median. In terms of previous birth, the same. In terms of cesarean section, 3%, 2.5%. In terms of multiple pregnancy, 1.6, 1.9. In terms of gestational age, in terms of preeclampsia, in terms of labor augmentation, everything was very similar, no statistical difference between these two facilities. Now the results are primary outcome. Out of the 48, almost 50,000 deliveries in the emotive side, we had 794 women that had severe PPH. And then in our usual care, out of the 50,000, we had 2,139. This shows a 60% reduction. So you can see we went for 25% reduction, but we ended up with a 60% reduction. Now that was really amazing. And when you look at, you know, the prevalence of the PPH from the two different groups, you can see the red is the usual care and the green is the intervention. When we started, they were almost the same, which is about 4% PPH, severe PPH rate. As we go along the transition, you can see immediately after the transition with the emotive intervention, the usual case maintained what it was. But because it was a trial, it was a bit better, but still at 4%. Whilst the intervention went down and continued to go down. Probably if we had continued this just for 7 months, if you had continued, it would probably get to 0. You can see it came down to 1 point something percent instead of the 4%. When you look at the key implementation, which means, you know, the diagnosis of PPH and the use of the compliance, the use of the emotive bundle. In terms of detection, 93% of the time in the intervention, they detected PPH, whilst in the usual care, only 50% of the time. That was what was there even in the literature before that. And then when you come to emotive bundle, even though they had all the components, but in the intervention, 91% of the time they used the bundle, while in the usual care, only 19% used the bundle. Now, this was also a real, you know, difference. In terms of postpartum hemorrhage, you can see that the blood loss just postpartum, not severe PPH. You can see that it was 8.5% in the intervention, whilst it was 16.7% in the usual care. And then severe PPH, we have said 1.6, 4.3. And then maternal mortality, we didn't go to reduce maternal mortality because, of course, you know, for maternal mortality, you need huge numbers. But we still followed it. And you can see that there was also almost, I think, a 20-something% reduction. All-cause maternal mortality, always there was also another reduction. Then you had the blood transfusion and then blood transfusion for other bleeding. We also did a subgroup and a sensitivity analysis between the different you know, countries, whether there was a difference, but it was found to be effective in all the countries, and there was no difference between each of the countries. And there was, in terms of 5 types of sensitivity analysis, none of which made any difference to the conclusion. Therefore, really, this is the result of emotive. We published this data in the International Maternal Newborn Health Conference in May 2023 in Cape Town. And the same day we published, you know, we presented the results. Our New England Journal of Medicine published our paper, and you could access it through this. That was when we published it. And immediately after, you can see between May and December. By December, WHO had updated its guideline on PPH management, and they have included early detection, assessment of blood loss, and use of the treatment bundle. Normally, WHO takes about 1 year to 2 years from evidence to policy implementation. That's the usual duration, but they did this within 6 months. This really shows that they were looking for answers, and as soon as they got emotive, they went ahead to actually as soon as this guideline is available, it came out on 23rd of December 2023. Countries started implementing or updating their guidelines. And all over Africa, many countries have updated their guidelines. In Nigeria, where I am, we are also at the and therefore, I'm sure within the next 4 weeks, we probably will have an updated PPH guideline for Nigeria. And already our federal government have given a go-ahead to roll out, you know, the new approach, because really, emotive is not a new intervention. Every single intervention in emotive have been proven a long time ago. It's just a new approach of treatment. having the early detection, and putting the treatment bundle together within 15 minutes. That is what we're saying. So actually now we're already starting, the implementation of training across Nigeria. And we're using our 41 e-motive sites. We have 41 e-motive sites that have continued to do implementation even after the trial. We finished the trial in April, May last year. And from that time onwards, they've continued to implement e-motive. We're using them as centers of excellence to now do training in the various states of other health facilities so that they will also implement the new WHO trial approach. Now, we also had implementation strategy along the e-motive trial. During the mixed method, the formative phase and the evaluation phase, we all did qualitative research. And we found 4 strategies for implementation. The trolley is where you keep all the components of the e-motive trial so that it is within the reach of the healthcare provider. So you must provide a trolley with everything inside, the oxytocin, the IV fluid, everything inside. Then you have to continue training. And then you needed champions. You need champions that will take that up and take it as their responsibility to ensure that the e-motive is implemented within their hospitals and support and mentor all the healthcare providers. Then audit and feedback is very essential if you want to carry along the healthcare providers. So these are the 4 strategies that we're using now in our implementation across Nigeria. Lessons learned: for you to do a real trial that has a global implication, you need a huge team. One person can't do it, 2, 3, 4, 10, 15. It's a team, and a team, each one has its responsibility, and we'll all come together to be able to do this global trial. You need the right methodology. We went on and on with the methodology with the best statisticians around the world, and at the end of the day we got the right methodology. You have to continue monitoring, because if we had not checked, as I said, we had to discard about 6 months data, we would have brought out a data that nobody will agree with. And at the end of the day, it's so important you monitor what you're doing. You've got to keep your research team engaged. And I think this e-motive team has been one of the best teams because we're engaged from day 1 up till today. You've got to have an excellent statistical plan right from the beginning, because as we're working, the statisticians were also doing their work. And then overall, you need an excellent leadership for you to be able to carry all these people along and to be able to get the results we have gotten. So ladies and gentlemen, in terms of conclusion, global burden of PPH is real and huge, especially where we come from. And we've identified the challenges that are associated with it. That is why we haven't been able to address it. And we've also found the answer to it. How do we solve these challenges? We've been able to get a new approach to it. And this e-motive new approach has actually led to a policy change. So really the time for us to change the directive and the trajectory of maternal death due to PPH is actually now. So we've got to act now. Thank you very much. And I'm ready to answer questions and comments.
I don't know if everyone heard that, but there was some good clapping in the room. So, so thank you both for these great presentations. I think we'll open the room for some questions. It seems like there's already some questions popping up in the chat. I guess I can start with Annabelle's question for Dr. Galadanci. Were there specific components of the intervention that you felt were the most effective, thereby conferring the majority of the effect seen on the composite outcome, or do you think the effect requires the entire bundle?
All right. So I think there are 2 components, 2 main things. One is that you've got to detect it. So if you don't detect it, you don't even treat it. So I feel if you're going to tell me which one is the most important, probably the first is the detection. Because if you don't detect it, then you don't treat it. Even if you have the best of treatment and you don't detect it, then it's of no use. But then the treatment also is important, because really just doing one intervention, which means probably the massage or the oxytocin, will really not work. So I feel the 2 components, one is the early detection, 2 is the bundle treatment. They have to go together. If you really want to see the impact, you've got to do the 2. I think if we decide on one, we probably will not see the impact, the cumulative impact. And that's why I think we had this huge impact. If we had decided on one, we probably would have seen a much less impact. But because we put the two together, I think that's why we have this huge impact. So for us to really reduce severe PPH, you've got to detect it first, and then you've got to use the bundle.
Thank you very much. We have a question from Joel as well in the chat, Joel Francis, for Dr. Neguse. Could you comment on the implementation science framework applied to your work?
Excuse me?
So Joel, I can repeat it or I can paste it in the chat as well. They said, could you please comment on the implementation science framework applied to your work?
Okay. Thank you, Joe. So basically, the framework that we used was just international health medical framework, where we identified the gap prior to just taking which one is the best way of the strategy to solve the problem on surgical site infection. And in order to identify that gap, we put the process mapping by engaging the team on the ground. So the context assessment and the process mapping is our way of understanding the problem than just proposing the solution as it is. So every system has got their own way of doing, and whatever works at one center will not work in another center. So the strategy of identifying the problem was what we used in order to implement the program as it is.
Great. I have a follow-up on that. It seems like there were perceived difficulties in implementation based off of the study. And did you see actual differences by sites? And do you think that some of these factors explain these differences? And if so, how do we use that preemptively moving forward with studies that are similar to this?
My internet is back. Did I hear you well?
Yeah, I had a question. So it was a follow-up question, and we'll see if the internet works now. But it looks like there were some perceived differences from the sites on difficulties in implementation. But the study itself doesn't specifically talk about the actual outcomes of the implementation by site. Do you think that these perceived differences were associated with actual outcome differences? Some sites doing better than others? And if so, how can you use those kind of baseline factors to improve your outcomes later on?
Perfect, thank you. So basically, the current study is a qualitative analysis on the perception from the implementers. So the original study, which is a clinical program by implementing the 6 compliance as a standard for preventing surgical site infection, those sites, the overall outcome is a 35% reduction on surgical site infection. And those sites where there is a compliance 4 out of 6 compared to less than 4 out of 6 has significant difference. So sites where there is good compliance to address the standards on the perioperative infection prevention standards at the baseline has a better outcome compared to those who have got less compliance. And this automatically showed that the culture at the institutional level in abiding to standards will have an impact on overall patient outcome. And whenever you are intervening these sites for changing their culture, the one which has a good compliance from the outset, the change is better than the one which has less compliance from the outset. But fortunately, in both, there is an improvement overall at the end of the intervention.
Thank you. I think Afra has had her hand raised for a while, and maybe she can ask her question.
Hello. Thank you so much for sharing all those presentations with us. I have sort of a more general question, and I think it's when you're considering implementing a package of interventions, do you ever ask yourself, oh, are we doing too much here? Are we not doing enough? And when or how do you gauge the scale of like a new intervention and whether that's going to be acceptable to, you know, in your setting?
Let me go first, then Dr. Galansi can continue. I think so when you have a package of interventions, during intervention at an institutional level, as much as possible, be simple, but be strategic. Because if you are having a lot of things to change at a time, then the buy-in from both the administrator as well as from the staffs will be difficult. And they will be biased toward this one of the package. So as much as possible, make sure that you are as simple as possible, but also don't take out what is important on the system. And the other one is whenever you're applying a package, it has to be interrelated. So they have to have relationship to as a system. So if you are just planning to intervene one on the checklist and going out and having another at the ward level, then it might be mixed up. Definitely for the analysis point, you can do just controlling the factors on the confounding. But for successful implementation of this program, there will be a bias. So as much as possible for assessing the change on your specific quality improvement program, be selective and be specific than just generally addressing a lot of issues at different areas. Thank you.
Thank you very much, Dr. Negusi. I absolutely agree with you. Be simple and be specific. And for me, I think supervision, mentoring, and monitoring is key. Because if you don't supervise those that are doing the intervention, they will do what they want. If you don't mentor them, they're not going to be able to do it. And that's why the champions are very important. So we identified champions in each of our sites, and we had a champion portal. In fact, we gave the champions a training on leadership and how they can carry people along so they could engage the healthcare workers and continue to support them and be able, because you can't be there all the time. The PI and the co-PIs can be in all the health facilities. But when you have the champions, they can answer questions, they can solve problems, they can make sure things are going on. And then if there's anything that happens along the research, you can identify it early and set up, machineries to solve it. So be specific, be simple, have mentoring, supervision, and support is what can make an implementation work. And of course, training. You have to really train them. They really have to be trained. And that's on and on and on. We cannot overemphasize the need for training. Yeah.
Awesome, thank you. I think our next question is coming from Dr. Rubiello. Do you want to ask it or shall I?
Sure. Way. Go ahead, you guys.
Okay. So the question in the chat was, can you tell us, Dr. Galadensi, can you tell us more about the preparation phase for the trials? How long did it take to bring together the team? Tell us more about processing all of the IRBs. Any thoughts on the possibility of harmonizing IRB approvals across institutions? What were the biggest challenges in bringing together all of the institutions?
All right. So actually the trial, plan took much longer than was anticipated, because I remember there was a plan of probably about, 6 months, and then we went almost 1 year. And one reason was actually it was just the COVID time. It was 2020. So most of our meetings had to be virtual. In fact, I learned how to do Zoom call during the emotive trial of, the COVID, because it was COVID time. The first meeting we had, it was a face-to-face meeting in Birmingham. And then after that, the world was closed down. So we now had to do all our meetings virtually. And we kept on doing meetings almost every week. In fact, selection of our sites We did them virtually, starting because even within Nigeria, I couldn't travel across Nigeria. So a lot of the things we had to do virtual. Some, some in terms of even the site initiation. So a lot of things had to change because of the current situation of at that time of COVID. So it took much longer than we thought, but I think it was worth it. I think that the plan, if not, wouldn't have gotten to where we are. And along the way, we are adding partners. We realized, I think, the need for each of the partners came on board, and they were fully implemented and fully incorporated. In terms of the different teams, a lot of us have worked together. Kenya had done a lot of studies with WHO. I had done studies with WHO. South Africa had done studies with WHO. So it was more like, go to the team that you already know, the team that can deliver. So the four of us had worked with WHO, and some of us had worked with JHU and all at University of Birmingham. But for me, I was working with Birmingham for the first time. But I think they got my contact through WHO, having done some studies with WHO. In terms of the IRB, I think it's going to be very difficult to say you harmonize the IRB because you know how IRBs are very sensitive and that's ethics. That's why it is ethics, and everybody will protect his own people. So I'm not sure they will agree to harmonizing IRBs across the board. But what is important is that if you have an IRB from, for example, WHO, and you bring it to my institution, it's easier for my institution to accept it than bringing an IRB that has not been approved by any other institution. So we had IRBs approved from University of Birmingham before we came to ours. So when we were now submitting ours, we submit with the IRB from Birmingham so that at least our IRB team will know that there has been another layer of screening on the ethical glass to make sure it is okay. And even when we're sending to the national, we had to give them the institutional IRB. I think each one will want to protect his own people. It will be very difficult for us to have a harmonized IRB. In terms of working together, I mentioned good leadership. I think we had excellent leadership from Birmingham. Birmingham University, Ari and his team were excellent in terms of taking us along. So they were able to, coordinate all the different, partners across the emotive trial team. So we're all together. We have meetings of every single partner together. We have meetings depending on whether it is the mixed method, whether it is the quality of drugs, whether it is the clinical trials, so different aspects of it. So I think the leadership is key. And there weren't any challenges, honestly. We loved working together, and I think we'll continue to work together. So we had no challenges.
Only a year is still impressive to me. It would take a few years to get off the ground. Looks like
Dr. Boatson, I believe, has the next question. She's had her hand raised for a while.
Thanks so much. Good morning, good evening, good afternoon, everybody. I'm Adeline Watson. I'm a OBGYN based here at Boston at MGH and Harvard Medical School. Thank you so much to both the speakers for joining us and sharing your work. It's so inspiring to see you both leading these efforts on the continent to improve health for women, and really dramatic and wonderful results from the trials that you've led. The question I have is a little bit two-part. So one of the things that I think is highlighted in both of your studies is how important some of the what I'll call non-biomedical components of the intervention are. So things like teaming, leadership, the organizational structure, who's involved, as you mentioned, Dr. Galancy, the champions and the training of the champions in leadership. And I think you mentioned also, Dr. Ngozi, that you had to have the organizational leaders on board to make sure the equipment was there. And I think so often, though, when those interventions that are bundled together and put in are then championed, people often focus on the biomedical components and not necessarily these other components and strategies that perhaps were the reasons that they worked. So I'm curious from your perspectives, how we get those components championed and also put in policy, perhaps in guidelines as well, and what that might mean also for the scale up and sustainability of these type of interventions if we're not necessarily focusing on them as much.
Yeah, so maybe I can start. Yeah, so I think what you've said is absolutely necessary. I feel this components of the intervention were actually what made it successful. If we had no champions, we had no teamwork, mentoring, we're not going to succeed. So what is important is that once we have an intervention, we should look at the implementation strategies, because basically that's it. What will you put in place for you to be able to implement that particular intervention? And let us not focus on, the biological aspect of it. So as you say, the non-biological. What are the strategies? What are the implementation strategies? And that's why I think nowadays that a lot of interventions, after even having proven efficacy of the intervention, the effectiveness, then we look at the implementation strategy. And what will help me in terms of my implementation in Nigeria might be totally different from what will be in Harvard University. So that's why doing implementation strategy within the context where you live and you want to implement that intervention within that context, then you can now do an implementation strategy research for you to identify the strategy. Or as you're doing your effectiveness trial, put part of implementation strategy questions in it so that you know what are acceptability, feasibility, fidelity, and all those implementation outcomes. How do you get them in your own context? And then once you get that, then you'll be able to implement. So absolutely, we need to take those into consideration.
Thank you, Adeline, for the question, and also Professor Kadazi on the response. One thing that I want to add is having a shared vision or understanding on the outcome is important. And when we say we need to engage leaders as well as we need to get a buy-in from all the stakeholders, it's just because what's in it kind of a reflection from these team members should be there. So if the patient's surgical site infection is reduced, what's in it to the surgeon, what's in it to the anesthesia providers, and what's in it to the leaders should be addressed before the program implementation is started. And if that what's in, for example, the cost to the hospital will decrease, the patient satisfaction will boost the surgeons and the team's satisfaction, as well as the compliance towards the standards will create a culture, a conducive culture where all the state members can work in. So if that is the case, then what were the barriers for this vision not to be achieved would be easily dissected out and would be addressed easily. So at the end of the day, what do we want to see after the program implementation should be discussed, entertained, and taken as a take-home message, then that would be the time you can start working on this implementation strategies. Thank you. Yeah.
Thank you both so much.
Awesome. A few more questions in the chat. Henry Rice sent me a message saying, for Dr. Neguse, wonderful talk, and I appreciate your focus on leadership engagement, which can be challenging in the implementation of many safety programs. Are there particularly helpful strategies to secure leadership buy-in? Some of that was already addressed, but if you have any other thoughts.
Thank you for the question. So when we say the leadership buy-in should be there, is because sometimes there are few things leadership decision really matters, even though the culture of the professionals, the implementers is there. For example, the purchasing power or decision on having tailors at the hospital level. It looks simple, but when it comes to the actual program, it's not simple. And even though the OR director or the surgeon wants to have alcohol hand rub, which doesn't look costly when compared to the normal alcohols that are like availing, then unless the leaders decide on purchasing those things, then that will not be implemented. And at the end of the day, the system or the culture will not change. So before we just started on implementing the program, the first meeting we need to have is, yes, the champion as the lead should be there, because as external person, you cannot preach about your program, but the surgeon or the anesthesia provider, whoever is the champion, should be with you whenever you are discussing with the leaders. And whenever you are discussing with the leaders, you have to tell them the details. What context assessment you are going to do, and what is the importance of that context assessment, and when do you think the leaders should be there. So you don't have to involve the leaders in each and every steps of the implementation. Once you tell them about the overall program, the vision, the outcome, and the specific areas of engagement, then they know when to be engaged, what to ask, and when to ask, and whom to ask. And if that platform is open to the leaders, then they understand about the program. If they're not happy about the program from the outside, they say, we're not going to implement the program. So you're not going to waste your time. But if they really understand the program, then it will be an easy track for you to continue implementing and showing them the change. And whenever you want a sustainability plan, it will be easy for them to take it from there. Thank you.
Awesome. Thank you for that answer. And I think we have time for maybe one or two more questions. So Nico Kumar in the chat asked for Dr. Galadansi. I was wondering if you could share more about what other implementation strategies you considered using during the training phase. Also, did you find that you had to make significant adaptations to these implementation strategies to the different contexts you were working in? And what was the experience like?
Yeah, so thank you very much, Nico. In terms of the training, we had to consider, you see, in the labor ward, you have midwives and you have doctors. And the doctors, you have medical doctors, you have consultants, you have house officers, you have students, medical students and residents. So first of all, we decided each and every member of the team in the labor ward has to be trained. So we're not only training doctors alone or training midwives alone or nurses that are in the labor ward. So every single personnel that works in labor ward had to be trained. That's number one. Number two is that you had to do continuous training, because unfortunately we are in an environment where they continue to change the healthcare workers. Today you find somebody in labor ward and the next day, unfortunately, they send her to postnatal ward or antenatal ward. And therefore they bring in new person. So we made sure that every quarter, if there are new healthcare providers that come into labor ward, then it is necessary that you train them as well. And then we used skill acquisition. We use actually mannequins. So it's basically basic skill acquisition. There was what they call the low dose, high frequency training of JFIGO, which means you keep, given information in low doses, but you do it more frequently. So that was what we're doing. So we were saying that like every week they can just come in and then with the mannequins, and then somebody goes through, the drill, trigger the bundle. What do you do? And then, you sort of refresh what you have done. I think that's very important, especially the skills with the mannequins. Because every health facility, the 40 health facilities, we left them with 3 mannequins that they could continue to do training. And the midwife, the leader, as Dr. Negusi was saying, is so important that the leader in the team or the leader, the leadership where you're going to have your intervention is fully taken along. Apart from the hospital management, the leader, that's the matron in charge. She was the person in charge and the head of the maternity. So she was fully involved, and in some places she's even the champion. We had a champion midwife and we had a champion doctor, so that the two of them were working together to ensure that the trainings are done and there's mentoring and there's supervision and there is continuous auditing. And as I said, there was feedback and auditing. So every month we give them their data. So what they're supposed to do is have the whole maternity have a meeting and share their data. So if last month you were picking PPH only 90%, this month you have gone to 98%, or maybe you have even gone back. So that's how we continued to keep them engaged with their data. Every month they could see their data and see how they have been improving, or see if they haven't been improving, or see if they are going back. In terms of the implementation, we had, in fact, the countries, there was a bit of a difference between the implementation in the different countries. The intervention was at 500 mils, you trigger the bundle. So once you have the blood in the drip up to 500 mils, you trigger the bundle. But we had another level, which is 300 mils. For us in Nigeria, we decided that at 300 mils, we already, if you have any other symptom, you trigger the bundle. And why do we say that? Because a lot of our women had anemia or have anemia. And then for us, you know, it's so few minutes between 300 mils and 500 mils. So we felt at 300 mils, you know, start triggering the bundle once you have either a raised blood pressure, a low blood pressure, raised pulse rate, or that the bleeding is just continuing, just trigger the bundle. I think somewhere in South Africa, they had to wait until it is 500 mils. So there was a difference in terms of implementation, and it's because of the adaptive side we had. The adaptive cycle was very important because it helped us to really analyze what we have and then to co-design the intervention together with the healthcare providers. So we had healthcare providers that had done the intervention in the 3 sites that we now worked together to now say this is what we want in Nigeria and this is what they want in the other countries. So definitely there was a difference with a different context, and then you need more than just the training, the champion, the use of skill acquisition beyond just didactic teaching. I just want to add here that, actually, I'm presently attending a T to T Harvard training. I think there is a Harvard Medical School training on how, teach to teach medical education. And I think this is part of what is very important in, adult education. That's why using, the knowledge, the skills, and the attitude is very, very important, and the new pedagogy of training of adults.
Awesome. Thank you so much to both of our speakers, Dr. Ngusi, Dr. Galadansi. Really good discussion, great papers. I think all of us could be better at implementation. So I think implementation science is very needed. So we appreciate you speaking to us today. I'm going to quickly share our mentee voting to see where everyone's coming in from. And I'll get us finished a little bit early. This is our last session of the academic year. So watch out for emails. Probably around September, we will start up again. Thanks, everyone.
Thank you.
Thank you. Thank you.
Thank you.
Thank you.